Welcome to the 2025 annual Plunkett Lecture. My name's Xavier Simmons and I'm Director of the Plunkett Lecture Ethics. The Plunkett Centre is a joint initiative of the Australian Catholic University and several participating partner organisations in the Catholic health and aged care sector, including St Vincent's Health Australia, Cabrini, Calvary Healthcare and Mercy Health. I would like to start this evening's proceedings by acknowledging the Aboriginal traditional custodians of this land, the Camaragal people of the Eora Nation, and I'd like to pay my respects to elders past and present. And thank you everyone who's joining us here in person. Also thank you to everyone joining us online. We've got over 100 people joining us online this evening. In terms of in-person attendance, I'd like to acknowledge in particular Reverend Dr. Gerald Gleeson, Deputy Vice-Chancellor for Catholic Mission at ACU, and also Mr. Matthew Carney, who will be joining us shortly, I believe, National Director of Formation and Purpose at St Vincent's Health Australia. And I'd also like to acknowledge the various executives, board members, trustees of our partner organisations joining us online this evening. ACU's Vice-Chancellor Zlatko Skribis sends his apologies for this evening. He's currently overseas on university business, but he's very much looking forward to watching the recording of tonight's event. And without further ado, I'd now like to invite Penny Wright to lead us in prayer. Penny is a trustee of Mary Aikenhead Ministries, which is an organisation that is the umbrella organisation of St Vincent's Health Australia. And so it's very great to have Penny here this evening, and thanks very much.
Let us join together here tonight, in person and online, for a moment of prayer, placing ourselves in the presence of God, the source of all wisdom and life. In the name of the Father, and the Son, and the Holy Spirit. Loving and eternal God, you are the creator of all that is good, the author of life, our source of wisdom and understanding. Bless the Plunkett Lecture Ethics, all its works and partners, as it brings a Catholic perspective to the great questions that shape human health and well-being. May our time together be marked by integrity, compassion, and respect for the dignity of every person from the first moment of life until its natural end. May tonight enlighten our minds through faith and reason for the common good and in the pursuit of charity and justice. As we reflect on the ethical challenges of medicine, research and stewardship of resources, fill us with the wisdom of your Spirit, help us to discern what is right and to act with courage and humility. May the Centre's work contribute to a world where knowledge serves love and where every human life is cherished as a gift from you. We ask this through our Lord Jesus Christ, your Son, who lives and reigns with you in the unity of the Holy Spirit, God forever and ever. Amen.
Thanks very much, Penny, for a prayer which I think captures so well our core values and mission at the Plunkett Centre, so thanks again. Tonight's lecture is the 16th annual Plunkett Centre Lecture. Our annual lecture is the highlight of the Plunkett Centre's events calendar, and we seek to select a speaker who offers a deep and novel perspective on issues of relevance to medical ethics and the Catholic intellectual tradition. Past speakers included philosophers John Haldane and Raymond Gaita, medical ethicists Daniel Sulmacy, Wendy Rogers and Lynn Gillam, Catholic Archbishop of Sydney Anthony Fisher, and constitutional lawyer and former ACU Vice-Chancellor Greg Craven. We thought long and hard about this year's lecture, and our speaker this evening stood out for us as a great candidate for his clear-eyed insights into issues ranging from euthanasia and conscientious objection to ethics education for health professionals, and also the role of doctors in engaging in policy advocacy. So it's my pleasure, therefore, to introduce Dr. Stephen Parnis, who will address us this evening. Dr. Parnis is a consultant emergency physician at St Vincent's Hospital in Melbourne and also the Royal Victorian Eye and Ear Hospital. He graduated from the University of Melbourne in 1992 and obtained his fellowship from the Australian College of Emergency Medicine in 2007. Dr. Parnis served as the president of AMA Victoria from 2012 to 2014, was chair of the AMA Council of Salaried Doctors from 2011 to 2014 and was also a member of the AMA Federal Council for a period of time. Dr. Parnis as well was the Vice President of the Australian Medical Association itself from 2014 to 2016. He is a Fellow of the Australian Institute of Company Directors and is also a Non-Executive Director of the Medical Insurance Group of Australia, or MEGA, having served as Chairman of the Board from 2023 until August of this year. In June 2023, he was appointed to the Board of Hearing Australia. Dr. Parnis has played a leadership role at state and national levels in progressing health and professional matters, including public health, industrial relations, and workforce policy, end of life, health funding, and medical ethics. Dr. Parnis led the campaign against the parliamentary bill which subsequently legalised assisted suicide and euthanasia in the state of Victoria. During the COVID-19 pandemic, Dr. Parnis' perspectives as a medical leader on the front line were frequently sought by political and public health leaders, and his perspectives have been regularly highlighted in the media. Since 2024, Dr. Parnis has been an honorary fellow with us at the Plunkett Centre, very happily, and we recently appointed him chair of the Centre's Clinical Ethics Advisory Committee. Dr. Parnis has been honoured with a fellowship of the Australian Medical Association since 2014. So Dr. Parnis will speak to us tonight on the topic of ethics in healthcare, principles or platitudes, and without further ado, let's give him a round of applause.
Okay, hopefully the microphone's working. I'll begin by acknowledging the traditional custodians of this land and the lands from which we all come. I would pay my respect to distinguished guests here tonight and all ladies and gentlemen, both here, colleagues, present in person and online across the country. It's an enormous honour for me to be here. And thank you, Xavier, for that very kind introduction. I would like to begin by acknowledging the man after whom this lecture, indeed the Plunkett Centre, is named, John Hubert Plunkett. As I read about his life and legacy, I came to understand not just why the Ethics Centre at ACU is named after him, but also that many of the themes that I will touch on tonight and have tried to live by would be familiar to Mr. Plunkett. His service from the 1830s to 1860s in the colony of New South Wales were noteworthy for his dedication to service, his integrity and indeed his ethics. As Attorney General in 1838, his commitment to justice fuelled his determination to prosecute over 2 trials the men responsible for the Myall Creek massacre of at least 28 Indigenous men, women and children. He did so against powerful vested interests and a considerable amount of public opinion. Never before had white men been convicted and punished in this way for killing Aboriginal people. I noted with pride his role as inaugural treasurer of St Vincent's in Sydney, where he was instrumental in developing the non-denominational character of the care provided there. All were welcome, not just Catholics. And if I wasn't already impressed with him, I discovered that he saw the light and moved to Melbourne for most of his final years, passing away in 1869. He comes across as a man who exercised his power ethically, and though many would have had disagreements with him, few would have ever disrespected him. A little about me. I am first and foremost a doctor. My clinical work has always been where I have felt most grounded and fulfilled. Over the last 35 years, I have grappled with the complex and intimidating beast that is our health system. I have spent years in leadership roles for the medical profession at state and national level, where considerations are not just about an individual patient, but about people and systems, competing demands and limited resources. I have learned that communication is arguably the most important skill in my toolkit, not just at the bedside with a patient and their loved ones, but in the office of a health minister or a CEO, and via the media and social media, where the audience is occasionally numbered in the millions. I would also emphasise that in what I do, communication must always be based on careful, empathetic learning. Put simply, my understanding of ethics is that they are a set of principles that guide behaviour, helping to define what is right and wrong. Medical ethics have been of profound interest to me since my earliest days as a medical student. It has always seemed to me that the technical and scientific aspects of medicine must go hand in hand with a robust appreciation for how to apply this knowledge safely and wisely. I have come to appreciate the so-called 4 pillars of medical ethics as a template to inform my decision-making process, often multiple times on a single ward round. They will be familiar to many of you. Beneficence or doing good. I think this is the reason why most of us enter the caring professions. Over the years, I have come to understand that this involves curing a patient far less frequently than I imagined. More often, it is about controlling a problem, advising and supporting a person who can be under considerable duress, and helping them endure their burdens, knowing they are not alone. Non-maleficence, doing no harm. This acknowledges that as doctors, we have the capacity to make things worse for people in our care. This can occur through avoidable errors over which we have control, such as a missed abnormality on a blood test or CT scan, and it can occur when we do not have control, such as an unforeseen anaphylactic drug reaction. Most people understand there are risks in medical care, and so our responsibility is to do our very best to advise treatment that where the options and potential benefits are maximised and the potential harms are minimised. And this is based very much on trust. With regard to autonomy, this is about respecting the rights of a person to make their own decisions based on their dignity as a human being. This imperative carries with it the need to understand a patient's perspectives, values, and understanding of the medical issues they face. In my area of emergency medicine, it often requires rapid assessment of a patient's capacity to understand, remember and make decisions, all of which can be impaired by conditions such as alcohol intoxication, severe infections, concussion, dementia and depression. Sometimes these factors are obvious, but at other times they are subtle and very hard to appreciate. The last pillar is justice. Among other things, I see this as ensuring fairness and equity in the provision of healthcare. We are fortunate to live in Australia, where universal healthcare has been embedded in our health system and psyche for decades. It is worth noting that until the establishment of our Medicare system, with its associated agreements for free public hospital care, the most common cause of bankruptcy in Australia was debt related to medical expenses. Sadly, this is still the case in an equally affluent nation such as the United States. I would add to the consideration of justice that there is a difference to equality and equity. Equality treats everyone the same, while equity treats people differently based on their individual circumstances to ensure fairness. A misunderstanding of this difference lies at the heart of many controversies in public health. If I were to summarise my view of the ethics of healthcare, a mission statement of sorts, it would be this: to provide care and protection for the vulnerable. It is my conviction that even the most powerful, articulate person can be vulnerable or at risk of harm at times. And my ability to provide care, to mitigate or remove that harm is both an obligation and a privilege we take on when we become doctors. I will now seek to describe a number of the lessons I have learned in the course of my career with regard to the place of ethics in healthcare. I will then focus upon the pivotal and painful circumstances that take place when one's ethics are put to the test. And finally, I will give some attention to the question of how best to develop ethical literacy and commitment among those in the healthcare professions. I believe the most important ethical decisions are rarely easy. It may be in assembling the complex information required to make a thorough assessment, finding sufficient time and space to consider the situation, exploring the options with the patient and their loved ones, and implementing an often imperfect solution. Emergency medicine demonstrates these difficulties on a regular basis. Emergency departments are often overcrowded, time-pressured and chaotic. The competing pressures for limited beds, staff, equipment, and the need for patient flow through the system to make room for the next ambulance arrival are incessant. Patients and their families, if they are fortunate enough to not be alone, are often under enormous duress, which may be due to pain, fear, uncertainty, language or cultural barriers, to name a few. And then we have to consider the ethical decisions at hand. I often care for the frail elderly patient brought to hospital following a fall at home. They're home for the last 50 years in many cases. They may have the assistance of family and friends, or they may be alone, lonely, and no longer managing the basics of life, such as nutrition and bathing. Stories from paramedics often describe scenes of squalor and distress at home. I have to assess whether that patient is safe to return home. And that recommendation or decision is complicated by the wishes or demands of family and the availability or absence of community resources, such as aged care packages. But most importantly, it is the wishes of the patient, their decision-making capacity, which may be compromised, and the levels of risk we are prepared to tolerate that we must reflect upon. In these situations, it is often difficult to not be affected by a level of duress myself. I seek to make the process easier by clarifying for myself and others the key points and priorities. Mindful of the resources available, I assess the timeframes needed for each decision, whether they be minutes, hours or days. And I determine the expertise and perspectives needed. In this case, the next of kin, the geriatrician, the social worker, the interpreter are often essential participants in addition to the patient. It makes the point that sharing the burdens of complex ethical decision making is valuable. It often enables improved decisions and acceptance of what I have described as imperfect solutions. The second lesson I have learned is that the doctor-patient relationship is often far more than that of a superficial and limited professional transaction, and it must be given the respect it deserves. Secrets are shared, trust is decided and conferred, and the stakes are high. Whether by personal choice or system design, the patient's well-being is placed in the hands of a doctor or healthcare team, and the legitimate expectation is that the care provided will place the patient's best interests at the top of the priority list. In fact, when a patient understands that I am putting their needs ahead of everything else, our interactions become much easier. It compels us to seek to understand the patient better, their beliefs, their priorities, and their red lines. Complexity and difficulties intrude when other interests have to be considered as well, such as other people's needs or the public interest as a whole, the expectations or policies of one's employer, and even the law of the land. Consider the patient whose infectious disease has put other contacts at risk, or the person whose injuries have been sustained in the course of committing a crime. Both of these cases require consideration of the balance between the right to confidentiality and the safety of others. Irrespective, the situation requires careful, respectful, but frank communication. As doctors, we have an ethical obligation to advise the patient of things they would probably not want to hear, such as a serious diagnosis. But to deny them that communication, to tell them what they want to hear rather than what they need to hear, that would be unjust and likely to cause even more harm. I have referred to the competing interests and influences of third parties, anyone outside the immediate doctor-patient relationship. And this brings me to the third lesson I have learned. Ethical decision-making must make every effort to understand the positive and negative impact of these third parties on the needs of the patient. At their best, a patient's family provides unlimited support and generosity to their loved one and makes the work of those in healthcare easy and joyous. At worst, there are times when one witnesses the distressing scenario of elder abuse. There are systemic factors that help or hinder ethical care. I have already referred to the Australian system of universal health care, but it is far from perfect. I am concerned about our system, which allows hundreds of thousands of international students to live and study in Australia and simultaneously be at significant risk with regard to their health care. They are not eligible for free medical treatment in our country, and their mandatory private health insurance often fails to adequately cover their needs. I recall more than a few examples where a young student with a potentially serious diagnosis had discharged themselves from hospital against my advice, principally due to fear of the resulting medical bills they may face, or due to pressure from family overseas, who fail to understand the risks their son or daughter may face. I recall a situation in 2015 when, as Vice President of the Australian Medical Association, I needed to defend the courageous decision of paediatric doctors at Lady Salento Children's Hospital in Brisbane, in their care of one-year-old baby Asher, a child who had been living on Nauru with their refugee parents. They refused to discharge the baby from hospital, knowing that to do so would result in their return to Nauru and the conditions that required the baby's hospitalisation in the first place. That decision brought the doctors and hospital into direct conflict with the federal government of the day, and that was a source of distress to all involved. The fourth lesson I have learned is a simple one: the need for humility and to acknowledge our humanity. The only safe and effective healthcare professional is the one who acknowledges their limitations and who is willing to learn from their experience, which will inevitably include making mistakes. We like to think that as doctors, nurses, allied health workers, we are the products of excellent training, that we have made considerable efforts over many years to acquire, maintain and enhance an impressive range of skills, and that we are willing and able to provide the sort of care we would like for ourselves and our families. I'm proud of what I do and of the teams of which I am a part. That said, I think we are now much more aware of some of the human traits which can undermine the care we provide. Cognitive bias in all its forms poses serious risks to patient care. We are all susceptible to relying on initial information at the expense of updated findings which require a change in diagnostic thinking, so-called anchoring bias. And I often see examples of confirmation bias, where a doctor seeks evidence to support a pre-existing belief, rather than to keep an open mind to entertain the possibility of surprising, less common and more effective treatment options. We have all been guilty at some point of not taking the stated concerns of patients as seriously as we should have. For example, it has been acknowledged in my profession that such shortcomings in the assessment of abdominal pain in women has resulted in serious missed diagnoses, provision of less pain relief, and increased patient distrust. In a similar vein, it is valuable to acknowledge that errors in healthcare, like any other field of human endeavour, provide important opportunities to improve healthcare. Early in my career, it was common to see medical error underplayed or denied, and even descend into a blame game, where involved clinicians were vilified and the patient met with a wall of silence. And now, while adversarial situations are still apparent, there is a much more robust culture in place. The priorities that are now encouraged emphasise open disclosure to patients, a determination to understand the structural factors which led to the error, and support for the clinicians as well as the patient involved. It is appreciated that the clinicians did not seek to cause harm, and that they can be particularly distressed by adverse outcomes for their patients. Which leads to my fifth lesson. Healthcare workers have an ethical obligation to care for themselves. In some regards, this statement is entirely pragmatic and utilitarian, because there is overwhelming evidence to show that unwell, exhausted, distressed doctors are impaired doctors. They have higher rates of medical errors, complaints and litigation. The proverb, "Physician, heal thyself," was already known when Jesus used it 2,000 years ago, as quoted in the Gospel of Luke. While the principle has been known for a very long time, it is only in more recent years that it has been taken more seriously. I find it useful to constantly remind my colleagues that the first letter in basic life support is not A for airway, it is D for danger, emphasising that if you are harmed in the course of your work, you are far less likely to be able to help others in need. A landmark study published by Beyond Blue in 2013 received information from over 12,000 Australian doctors and 1,800 medical students. It confirmed that in comparison with the rest of the population, doctors suffer substantially higher rates of psychological distress and suicide, particularly younger, female and hospital-based doctors. Contributing factors such as excessive work hours, the responsibility of the job, fear of making mistakes, bullying and racism were all identified. Significantly, a major barrier to seeking support and help was the perceived stigma surrounding mental health, the belief that disclosure of anxiety and depression would negatively affect one's career prospects. I take this opportunity to remember too many colleagues and friends who have taken their own lives. The shock, devastation and pain they have left behind never fully heals. It fuels a desire to improve the culture of the medical and caring professions, to promote the same care for ourselves that we give to our patients. This is a complex and challenging area, not only for healthcare professionals, but for their families, employers, colleges and universities and regulatory bodies. We have a long way to go. In early 2022, after two of the most demanding years of my career confronting the COVID pandemic across multiple clinical and professional roles, I was confronted with the reality of my own burnout. My wellsprings of compassion and empathy were running dry. My confidence was undermined and my emotions were labile. With the support and guidance of my GP and psychologist, the understanding and encouragement of my colleagues, and the love and patience of my wife and family, I took time away from my work to recover. I returned 3 months later with a renewed sense of purpose and gratitude. And I hope my example made it easier for others in my profession to recognise the need for work-life balance and better self-care in their own lives. I now turn to a difficult area. When the ethical principles and practices of an individual are put to the test. There is nothing new about this. History is full of examples of people whose career, reputation, and even their very lives have been sacrificed as a result of their principled conduct. The names and example of Thomas More, Emmeline Pankhurst, Dietrich Bonhoeffer, and Nelson Mandela will always be remembered. In my opinion, I believe that one has to be prepared to pay a price for upholding ethical principles. If that is not the case, then it really is a form of hypocrisy. That so-called cherished principles are treated more like platitudes, ready to be abandoned in the face of self-interest or potential adversity. Only last month in Portugal, the General Assembly of the World Medical Association adopted a resolution to uphold the ethical framework of healthcare. In its preamble, the WMA states that pillars of medicine which were until recently considered unquestionable, such as scientific evidence, human dignity and solidarity, are being increasingly challenged by the expansion of ideologies and political positions that reject or deny them. In this context, the ability of physicians to work ethically and to follow the rules of the profession is threatened, as is also the autonomy of the profession. The intervention of politics, of the judiciary system or of the police in the care process is increasingly becoming a reality in many parts of the world. I have to say that with over 30 years of experience in the medical profession, I feel it has never been more onerous to practice ethically than it is today. And unfortunately, there is no shortage of examples in contemporary life or my own personal experience to illustrate this point. In only the last few days, the hospital where I have trained and worked since my earliest days in medicine, St Vincent's Hospital in Melbourne, has been subjected to a torrent of vitriol and abuse for its laudable work in improving health outcomes for Indigenous patients. Most Australians are well aware that Indigenous people experience worse health outcomes than almost any other cohort. Life expectancy, chronic disease rates, addiction, mental illness. Closing these gaps has been a difficult bipartisan national priority for many years. True to its core values of compassion, integrity, justice and excellence, St V's looked at the evidence which showed that Indigenous people waited 3 times longer than non-Indigenous patients and were 3 times more likely to leave emergency without being seen. Using the tool of triage, which is a form of emergency medical assessment of severity, urgency and risk, along with improved education and resourcing to help clinicians provide culturally safe care, we have seen improved outcomes. Just as importantly, there has been no compromise to the care of any other group. To be on the receiving end of accusations that we are promoting queue jumping or racism is disappointing, to say the least. But I'm proud of the fact that St Vincent's will stay the course on a practice which is equitable, ethical and effective. In recent years, and for reasons that are beyond the scope of this lecture, the science and indisputable benefits of immunisation have been subjected to more and more criticism and misrepresentation by those whose perspectives are far from scientific and particularly ideological. Immunisation has been saving lives since Dr. Edward Jenner made the link between cowpox exposure and smallpox prevention in the 1790s. And diseases such as polio and diphtheria are to be found in historical records rather than in contemporary clinical settings. However, vaccination policies and resources are being systematically undermined in some surprising parts of the world. There is no clearer example of this than in the recent sacking of Dr. Susan Monares as Director of the United States Centers for Disease Control. Monares, a highly respected infectious diseases clinician and researcher, was fired for refusing to sign off on reckless, unscientific directives on vaccination policy, and for refusing to fire dedicated health experts at the CDC on ideological grounds. I think the politician who fired her, United States Health Secretary Robert Kennedy Jr., can fairly be described as an anti-vaccine activist and conspiracy theorist. And his efforts to override scientific evidence and ethical experts will result in avoidable harm to vast numbers of Americans. We talk a great deal about respect for patient autonomy as a fundamental ethical principle. Yet sadly, we are witnessing the progressive erosion of professional autonomy, a fundamentally important aspect of safety and excellence in healthcare. In my profession, self-regulation by bodies such as the Medical Board and learned colleges is being gradually overridden by aspects of administrative, employer and political overreach. Striking a fair balance between self-regulation and external accountability is essential. As my colleague, GP and academic Associate Professor Louise Stone has said, on the one hand, too much autonomy creates an opportunity for bad professionals to do bad things. The bottom 5%, I would argue a lower number, of the profession may well behave badly and hurt people without sufficient regulation. This should be why regulation exists, to sort them out and get rid of the ones who exploit their professional power to profiteer, leaving damaged patients in their wake. However, if professional autonomy is curtailed too much, the innovators, experts and masters have no flexibility and no capacity to do what they know to be right. I agree with Louise and extend this to the consideration of ethics in clinical decision. I fiercely defend the right and necessity of allowing healthcare professionals to exercise conscientious objection. I believe that as a doctor caring for my patient, or as a professional leader advocating for ethical practice at a public policy level, I am obliged to assemble the relevant information and critically appraise it with all the skill I have. Then, with respect for the autonomy of my patient or community, I am required to offer my best advice and recommendations. I will be respectful of their decisions, whether I agree with them or not. But I should not be forced to participate in a practice that I regard as harmful, dangerous and unethical. I and my colleagues have a right not to be subjected to injury, the consequences of which have led gifted health professionals to stop practicing their vocation in healthcare altogether. Doctors are not vending machines, and provided we do not seek to impede a patient's access to a legal service, we should not be forced to facilitate it. As always, the exercise of such conscientious objection must be framed in empathy and respect for the patient or community. What applies for the individual healthcare professional in this regard is equally applicable to healthcare institutions. I have spent almost a decade articulating my opposition to the legalisation of assisted suicide and euthanasia, also referred to by the more sanitised term voluntary assisted dying. And I know many healthcare institutions share my position. I do so on the grounds of patient safety, that the push to facilitate a new choice for dying patients is overly dismissive of the new risks imposed on an incredibly vulnerable group, that they are made to feel they are a burden on others, that they are presented with a choice of rapidly available lethal drugs or patchy, delayed palliative care and community services. I believe my position has always been articulated carefully and respectfully, acknowledging the good intentions of those who disagree with me and seeking to appreciate the complexity of the issues and the sensitivity and emotions involved. A common responsibility for most doctors. And yet, I have lost count of the episodes of ad hominem attack. The efforts made to discredit me by reducing debate on a critically important issue to a simplistic assertion that he must be doing this for religious reasons. If we lose the ability to respectfully disagree with and learn from each other, we will have lost something precious, and our collective values and conduct will suffer accordingly. I now turn to an issue that has caused turmoil around the globe for the last 2 years. The murder of 1,200 Israelis and capture and torture of 250 hostages on the 7th of October 2023, followed by the destruction of Gaza, deaths of at least 70,000 Palestinians and displacement and starvation of millions. I do so to further explore the way the ethics of individuals and institutions have been put to the test in our own country over that time. At a time of profound grief and anger, we have all seen a deeply regrettable rise in Islamophobia and anti-Semitism, the unmasking of intergenerational trauma we had all hoped was left behind in the 20th century, and frustration at the seemingly eternal cycle of violence playing out in the Middle East. As a community of doctors dedicated to the alleviation of suffering, with expertise in disaster management and critical appraisal of evidence, I was not surprised that large numbers of Australian doctors and medical institutions have sought to analyse and engage with these disasters, with the express aim of pursuing the ethical objectives to which we are committed. However, for the first time in my career, I have been alarmed to see the cancellation of forums related to this and other humanitarian catastrophes on the grounds of safety. I cite 2 examples. One in November 2023, with the late cancellation of a pre-recorded keynote address for the annual scientific meeting of the Australasian College for Emergency Medicine by an emergency physician with a long history of humanitarian work in Gaza, Jerusalem, Jordan and Syria. The other was the late cancellation only a few weeks ago of the Royal Children's Hospital Grand Round in Victoria, whose title was Children and War. It was convened to explore themes of humanitarian principles and child rights, refugee health and trauma-informed care, nuclear war threats and lived experience of conflict. It is not for me to pass judgment on these institutions, but I will observe this, that doctors are expected to engage in difficult, complex situations in individual and public scenarios every day, and that we are now seeing direct clashes between the interests of those we care for as doctors and the interests of those who employ us. My own personal experience in advocacy on the issues relating to the carnage in Israel and Palestine has been painful to say the least. As I did during the pandemic, I have sought to present a doctor's perspective on a complex and difficult situation, subscribing to my lifelong commitment to protection of the vulnerable. In this case, I have advocated for the protection and needs of healthcare workers in Gaza and Israel, and the protection of innocents, particularly children. I have sought to be measured, to respond to hostility with empathy, and to be equally critical of indefensible conduct on either side of this conflict. Nevertheless, and like a number of my medical colleagues, I have personally become a target for some of those who disagree with me, who have sought to silence and punish me. I have been subjected to more than one complaint to the medical board, thankfully investigated and judged as meriting no further action. However, I have been compelled to resign as the board chairman of a company I proudly led until August of this year. As I remain on that board, I'm unable to speak further on that matter, but I will say this. I stand by every word I have said in the public domain on Gaza. A common tactic used by critics against health workers is the stay in your lane ploy. No example is more famous than the efforts of the National Rifle Association in the USA, who called for self-important anti-gun doctors to stay in their lane in 2018. Dr. Judy Melinek, a forensic pathologist, was preparing to perform another autopsy on a gunshot victim when she responded. How dare they tell us to stay in our lane, when actually it's the other way round? Do you have any idea how many bullets I pull out of corpses weekly? This isn't just my lane, it's my highway. She used slightly more florid language than that. In closing this aspect of the lecture, I pay tribute to those many members of the caring professions who have paid the ultimate price for living and practicing according to their ethical principles. Dr. Bernard Quinn was a government medical officer serving on the Australian-administered island of Nauru when Australia evacuated its administrative offices on the 28th of February 1942. He elected to stay behind as the island's medical officer, during which time the island was occupied by the Japanese. As a reprisal for the first American raid on the island, Dr. Quinn was executed by the Japanese on the 26th of March 1943. Dr. Jane Connor was a young Victorian doctor of my vintage, whose passion lay in caring for the victims of disaster. She served as a medical officer with Médecins Sans Frontières and was in Honduras in November 1998 during Hurricane Mitch. She was killed in a helicopter crash while retrieving a critically ill patient, and she was 29. I hope it is apparent to anyone with more than a passing interest in safe and effective healthcare to appreciate the need for medical and other professionals to be well versed in ethical principles which underpin our work. To that end, I would like to consider how best to develop ethical literacy and commitment to the caring professions. I appreciate and respect the role medical educators have played in teaching and modelling the ethics of healthcare in our professions. I vividly remember attending my first ever lecture as a medical student, 2nd of March 1987, which was focused on ethical principles. I remember the images of doctors caring for their patients and the quiet, eloquent case made for these principles by a senior physician named Professor Jim Best, whom I would later go on to work for at St Vincent's Hospital. A few years after that, when he was head of the Melbourne University Medical School and I, the Victorian president of the AMA, I recall some fairly robust but respectful discussions about important priorities in the selection of medical students. This relationship reminds me of a number of factors which are required to prepare ethical clinicians. They range from selection criteria to places in the medical curriculum, to the modelling of ethical practice, to the place of reflective practice and ongoing learning, and finally to the support of employers and professional bodies. With regards to the medical student selection, and I'm being approached by a medical student as we speak, I welcome the diversity that is now apparent in medical school intakes. There is no doubt in my mind that a broad demographic base in the healthcare professions can only enhance our capacity to appreciate and work with the cultural diversity of Australia's population. This, together with the fact that medical students are now more likely to be postgraduate students with greater life experience than in my era, gives me cause for optimism. I am also gratified by the fact that communication skills, a fundamental aspect of ethical practice, are considered to a greater extent than purely academic performance. To be a so-called brilliant doctor is no guarantee of providing ethical, compassionate care. It is fair to say that the scientific knowledge and capabilities underlying healthcare have expanded at a breathtaking pace over the last century. While this of itself is a wonderful thing, it has tended, in my opinion, to compete for space in medical education at the expense of some of the domains which support the appreciation of professional ethics, such as the humanities, academic disciplines that study culture, history, literature, philosophy, religion, and the arts. Processes in student and postgraduate education which nurture these humanities are to be encouraged, because medicine remains a social science deeply influenced by politics, economics, and interpersonal relationships. Healthcare training, particularly in the medical profession, has used the apprenticeship model for millennia. In the context of professional ethics, the example set by senior colleagues could not be more important. While the content of my lectures and tutorials from decades ago may have faded, the example of some of the senior doctors I have worked for and with remains as a guide, many years after some of them have passed away. I would like to mention two of these doctors. Dr. Andrew Dent, the man on the left, was the man who contributed the most to my decision to become an emergency physician. 17 years after his premature death, I and so many of my emergency colleagues remember his commitment to society's most downtrodden, the homeless, mentally ill and prisoners, to name a few. He treated them with profound respect and in turn they responded so positively. His care was not just at the bedside, but in his continual efforts to improve the healthcare systems that helped us all do better for these patients. Professor John Murtagh, who died only a few days ago, is rightly regarded as one of Australia's greatest general practitioners. For me, he was a gentle but authoritative mentor as I grappled with what I should do in my years as an AMA leader and beyond. His support and reassurance on the many occasions when my advocacy antagonised powerful bodies remains with me as a source of wisdom and generosity. To this day, I try as best I can to offer my own mentorship and example to tomorrow's medical leaders, and I encourage my senior colleagues to recognise their responsibilities in this regard. My final consideration is the role of professional bodies and employers in the value and practice of professional ethics. To governments, regulators, universities, colleges, hospitals and health services, I say this: you train, certify, oversee and employ doctors, nurses and allied health workers. You rightly expect excellence and commitment from these professionals because it is a privilege to deliver that care. However, you should all acknowledge and respect the fact that our primary duty as clinicians is to our patient, and that will inevitably place us and you in difficult situations. I ask that you show the same care and concern for us as we show for our patients, and to recognise that there are times when it is impossible to act ethically and satisfy every competing interest. If you support ethical clinicians, their influence and impact will flourish. If you do not, you inadvertently encourage a harmful culture where self-interest trumps principle. In that scenario, nobody wins. Thanks.
Thanks so much, Stephen. And I would just like to very briefly thank Stephen for a clear and broad-ranging, thought-provoking lecture. And also just, it's a bit of a lesson in how to communicate clearly. I think when you hear Stephen present, he's just a very crisp, clear presenter. So very grateful for so many insights. And as someone very interested in the conscientious objection debate, I found Stephen's reflections on the difference between a principle and a platitude particularly helpful. And that definitely resonates with a lot of what I've read in terms of what people say about when conscientious objection should be permitted, that you've got to actually really believe what you're supposedly acting on when you voice a conscientious objection. And I think that Stephen's given a very clear articulation of what that means in practice in medicine. So thank you so much. And we've got about 20 minutes for questions, and we are going to have a mic just to try and amplify people's voices. But while we're getting that set up, maybe if there's an initial question, someone can just, Pip's got the mic ready to go. So just put up your hand if you've got a question for Stephen. There's, I think, ample material to discuss from the lecture, so please do raise your hand if you have any questions or comments. I just ask that you keep them brief. Thank you.
Thank you so much for your talk. My question pertains to the former half of your talk. You quoted, physician, heal thyself. And as a future physician myself, I may one day be working 100-hour weeks. So what are your personal tips for me and other future physicians as to maintaining a work-life balance when having to deal with such hours? Thank you.
Good question, thank you. I hope the system will have continued to improve such that you don't have to work 100 hours. I did work that. I was training to be a general surgeon before I moved into emergency medicine, and that is one of the factors that made me think I cannot do this. And as I said earlier, if you're exhausted, you can't provide care, you suffer harm. There's plenty of evidence that shows that. I like the irony, and I take that proverb a little bit more literally than most, because I'm a doctor, as you will be. The message is to everyone really, which is look at yourself before you start commenting on others as well in some ways. Again, it's a warning against hypocrisy, but I think we try and leave the place better than we found it. And I think that the criteria that you will use in choices you make through your career should have as a priority what is it that allows me to be my authentic self, that allows me to practice safely, and some of that will be personal interest, and that's okay. I hope that answers the question.
Oh, thank you.
Better not stand there, too bit bright.
Hi, Dr. Parnis. I'm Marilyn Rodriguez from the Catholic Weekly newspaper in Sydney. You spoke so clearly and so beautifully about conscientious objection. I just wanted to ask whether you felt that there is broadly, I guess, in our culture, an understanding of conscientious objection on the part of, from individuals or organisations, and whether there's less, well, I guess, understanding about what it means, and also far less tolerance for it. So, as you would know, there's a push in various places, including in Victoria, to really look at who are the conscientious objectors and make sure that they're sort of closely looked at. And sorry, now I've run out of words, but
answer is yes, yes, yes. Next
yeah.
question.
So
No,
basically, whether there's an understanding about it and whether there's less tolerance of it.
I've seen, and again, people like Xavier and Bernadette would be much more across contemporary debate within the ethical and philosophical professional communities. But my sense, looking as far back as the 80s, is that yes, there is less tolerance for ethical or conscientious objection. I think there is less understanding of it, and we live in a society now where everyone's entitled to an opinion irrespective of whether they have any expertise or knowledge in the area. And things get oversimplified or dumbed down. That's a very different proposition to needing to simplify complex concepts. And you can do that sometimes, but striking the balance is, I suppose, the task of my professional lifetime. I think, yes, the case continues to need to be made. Unfortunately, there are some regulators, some ethicists and governments who are less inclined to accept it and are very quick and easy to dismiss what constitutes participation in a morally repugnant act. And it does cause harm. Again, let's use my own state, Victoria, as a microcosm. I am aware, because I was on the personal receiving end, along with many of my colleagues, of enormous expressions of respect and gratitude for the work we did during the pandemic, because a big part of that was putting ourselves at risk, looking after people whom no one else was able to see because of the risk of a virus that we hardly knew anything about, let alone were able to treat. And yet, fast forward to a few years later, and we're now looking at the legislative debate about amendments to the laws for being able to take one's life of one's own accord. There is a provision in there that would compel doctors and other health practitioners to hand over a pamphlet, not even knowing what that pamphlet says, something that's determined by a bureaucrat in the State Department of Health. That of itself, not to everyone, but to some people, would be sufficient to constitute participation in a process that would do terrible harm. And I think that provided we don't stand in the way of the patient, and someone tell me that in 2025 patients don't have access to these things or can have alternatives to access, that forcing a health professional into a corner, a form of entrapment sometimes, that is decent or appropriate, let alone professional or ethical.
Hi, thank you for your talk. I am a medical researcher, so a little bit outside of the scope of this talk, but you did touch very briefly on the distrust that there has become growing amongst the general population with regard to scientific research. And I just wanted to get some of your thoughts as to the ethical quandaries of dealing with people who distrust the scientific professions, distrust scientists, distrust the data, and how you go about communicating to them where you stand on these issues and how you communicate to them your stance on certain issues like vaccination. And then I also wanted to touch briefly on and ask you about the idea of misdiagnoses and the role that science research can play in informing doctors. Yeah.
Two very distinct but critically important areas. So how do you build trust? And my job is close to impossible without trust. Now, there are clearly people who are comatose in the resus bay where it's one-way traffic. They can't communicate. I have to take their best interests to heart. I am mindful of the paternalism of that, but I also know and hope that they would want me to be doing everything for them if they were able to say so. How do I build trust? In my work, principally as a clinician, I've never really been patient enough or eloquent enough to do research, I have to say. I get published in the news media rather than learned journals. But I think it's the same in both fields. The recipient needs to know that you know what you're doing, and they need to know that you care deeply for them. The number of times when I have said, I make a decision or a recommendation by putting my sister, my brother, my father or myself in the bed where you are now and thinking, is this something I would want for them? If yes, I recommend it highly. If not, I go back to the drawing board. And that conveys that message. There are times I can gently persuade, and it's not easy wanting to spend 15, 20 minutes with someone in emergency when the phone's going nuts, there's the next ambulance going into resus. So juggling all of that is a distraction, it is hard, and handling multiple balls in the air is not an easy skill for even someone who's been doing it for decades. So I think there are times when it's clear to me I am not going to change someone's mind. I might look for an alternative view. The lovely thing in my work is that I've always got colleagues with me, always, and they may be able to do it. Sometimes it's the messenger rather than the message. If I have a deeply traumatised victim of domestic violence who is usually female, then having a female colleague involved in their care can achieve things that I could never. So considering every aspect of the dialogue, trying to understand why that is. Many people have had traumatic experiences in healthcare and they are reacting to that trauma. Hospitals, in my line of work, are the place where their loved ones die, where they have had pain, where it's scary, where you don't know who people are. So you see people when they are at their most vulnerable, when they are least likely to appeal to reason. So I hope that gives you a few things to think about there. You know what you're doing and that you care deeply. If you've got both of those, then I think you are as far along as you can be. On the issue of cognitive bias, I'm very fortunate because the director of one of my emergency departments, the Eye and Ear Hospital in Victoria, her name is Associate Professor Carmel Crock, and I would say she is one of Australia's leading academics in the area of cognitive bias. And even just talking or listening to her about the way that bias intrudes into our decision making, these are things that I reckon have made my processes a little bit better. If you're a hammer, everything looks like a nail. If you are a pharmacist treating someone with blood in their urine, yeah, it could be a urinary tract infection that you learnt on that brief course, but what about the malignancies? This is my fear about some aspects of scope of practice change. And I say this with all due care and respect. I work with pharmacists and other specialties every day. We conduct the orchestra and we make beautiful music together. So understanding those biases and allowing those pivotal moments to confront your thinking. I remember treating a homeless man who I told had a metastatic cancer and a terminal diagnosis, and later finding out the man had been a barrister. That confronted me in a big way, because you have these pre-existing cliches. We're all human. I think to deny it is unhealthy. To acknowledge it and learn from it, that's where the humility that I talked about earlier comes in.
I was interested that there was criticism of your Aboriginal health program in emergency. What do you think is underlying that, and what sort of strategies will you have to address it?
I think that it's revisiting some of the issues that as a nation we confronted during the referendum debate. Again, misunderstanding equality and equity, I think. I sometimes use an interesting forum, X or Twitter, to get messages out, and sometimes I can get messages out to hundreds of thousands in that way. But on this one, and again, conflict sells or conflict gets an audience, there's a lot of abuse, a lot of oversimplification. The thing that I think about more commonly is when the descent into things like queue jumping or racist policy comes from people who I thought would know better. That said, I know that I could come across as condescending, paternalistic, disrespectful of people who have contrary views. You've got to keep working at the empathy side of response to hostility. So trying to discover where those feelings come from, and we have a lot of people, and now I'm delving into the realm of politics and sociology, a lot of people who feel disempowered, disenfranchised. They can't afford a house. They are unable to work where they want. They feel that the system is letting them down and it's looking after elites, whoever they are. They're the sorts of people who will push back, whether it's with their vote in an election, whether it's on social media at whom they see as an elite. These are the sorts of circumstances there are, and I think the challenge for our political leaders is to seek to be able to answer their grievances without necessarily raising a white flag on the principles in order to be popular. And that's a challenge for a lot. I've long said that in Australia we gravitate to the centre with our voting system and of compulsory voting and preferential voting. That's not the case in other parts of the world, and I think the US is an example of polarisation, of extremists being elected into positions of power and doing harm along the lines of the examples I've presented. So this is a huge area. Again, a friend and colleague tries to explore this. Father Frank Brennan, the Jesuit, who has given his life to many aspects of Indigenous policy. I am looking forward to picking his brain on this one as well. So we can't be dissuaded from doing this. You've got to keep making the point. Repetition's essential, but you also have to be prepared to pay a price.
Peter Grace, Head of Mission Services with Calvary Healthcare. Thanks, Dr. Parnis, for speaking with such passion and conviction. As a Catholic health provider, we of course have a stake in the education and formation of our doctors and nurses and allied health professionals, and you alluded to the fact that there may be some shortcomings in terms of the way in which our young people are taught to navigate those basics of being a medical practitioner. My question is that, I suppose, in light of some of those shortcomings, what are some of the strategies, in addition to your response to my friend's question about the 100-hour weeks, but in addition to some of those things, what strategies would you recommend for people, both prospective students, current students, and in fact those who have graduated, in terms of seeking a deeper understanding of navigating what are sometimes conflicting priorities?
Thanks for the easy question there. You know, I still find in my 50s that I am surprised, disappointed, devastated sometimes by the inconsistencies, the injustices that occur in our world. In any area where there's more than 2 or 3 people, there's going to be politics, there's going to be uncertainty, ambiguity, difficulties, and so trying to work through those things. I've encountered some myself recently in university administration, for example. I think I have the advantage of drawing on personal experience now and being able to say, well, I've been able to negotiate, navigate through this. I call on trusted people. I know whose strengths I need at this time. I know if I'm persistent, I will get there. I know that chances are the outcome won't be exactly what I wanted, but it'll be all right, and with hindsight, it'll be the best. And I would like those things for young people moving through the professions to experience as well. I think nothing speaks more loudly than the power of example. And as I said, if you're a senior clinician or an institution and you have this circumstance, and it's the difficult circumstances that get the most attention, that's the test. So will you support what you perceive to be ethical behaviour? Will you back down? And people will remember those things. I think a culture of censorship, for example, and I use those 2 examples of those cancelled meetings, I think that's corrosive. I really do. I know it's playing out in different ways in different places. And how to nurture people developing those opinions. I would love to see, for example, a younger doctor say to the older one, look, I respectfully disagree, or why did you go down this path? I might have gone the other way. Now, we are, even these days, a very hierarchical profession. It's like the military. People are fearful that if they say or do the wrong thing, that's their career. But I had a message from a surgeon I worked for when I was an intern way back in '93, and he said, his name was Steve as well. Steve, you know you're an intern and I'm a general surgeon. I said, yep. And that means that I can teach you a hell of a lot about general surgery. I said, yep. And I'm thinking to myself, where's this going? And he said, but does that mean I can teach you a hell of a lot about everything else? And I'm a 23-year-old firebrand at the time. And I said, I don't think so. And he said, good, because I thought that was going to spark an argument. But he said, good, don't ever forget that. So there's the institutional policies, for example, paid overtime. Didn't exist in my time. That's an industrial thing, and it's about value and it costs money. But look at the institutions that are now being compelled by federal court action to pay an enormous amount of money. You come from Calvary. I want to pay tribute to Calvary. I know from the input of my colleagues in the ACT that Big Calvary Hospital differed from the other public hospital in more than one way, and the culture of care and support for their staff was an incredibly important part of that. And I hope now that the ACT government has taken it over, that the culture percolates across to the other entity, not gets diluted. So policy and individual opportunity. That's my humble take as someone who's avoided being in a senior administrative role for his entire career.
Might just take one more question. If there was a question over here.
My name is Keith Hartman. I'm an obstetrician and gynaecologist. I graduated 55 years ago, and I've been an obstetrician and gynaecologist for 45 years. In the last 7 or 8 years, since my retirement, my preoccupation has been largely with the establishment of a palliative care unit at the Mater Hospital. So I've thought about both ends of life quite a lot. I worked over those decades in public secular hospitals and Catholic hospitals parallel, and I've never shied away from my stance, particularly being an obstetrician, on the question of abortion. I'd have to say I've been respected all along the way, from when I was a junior resident, when I went to Oxford, where 1 in 4 pregnancies was terminated, but I made it clear on the first day that I wouldn't be participating, and that stance was respected. It was exceptional. So much so, when I left 3 years later, the professor, who was a world-famous person, gave me the most extraordinary reference, but he couldn't help himself. He had a paragraph in it which I show to students every now and again. Dr. Hartman is one of the best registrars we've ever had. However, he has an unusual view of abortion. It was pointed out in my reference, which I thought was a bit beyond the pale, but anyway. My point is that my stance has been respected, and obviously in Catholic hospitals it's easy because the institution and I have been aligned. In public hospitals, particularly, when the argument is used, what we're proposing is a legal procedure, it's funded by the government, and, it's an expectation of the public that this is available. And it's an expectation of the institution that people who work here participate. I've never had a problem. I've been on the staff of North Shore for 30 years or something, and it's never been an issue. It's been a subject of debate and a lot of discussion and a certain amount of ridicule from time to time, especially when the abortion laws were changing about 30 years ago. I had one cynical tutor who'd say, "Hartman, tell me the Catholic position," in a tutorial, which I was very happy to do, but it was sort of seen as out of the field.
Yeah.
But I'm moving to the point. My worry is now that I see my own college, of which I'm still a paid up credentialed member, putting more and more pressure on trainees that the provision of services, in the case of obstetrics abortion, is part of their training and they have to be involved in it. I agree with you, conscious objection is a principle, it's just a human right in my view. But I see that being eroded, and it will probably be eroded in subtle ways that people will get. There will probably be some way of, at an interview level, just working out who's going to be the troublemaker and who's not. But it's becoming more and more one-eyed, which is not what I've experienced. And that really worries me, because I still tutor at Notre Dame, and when they do an obstetric term, about 8 out of 10 students don't want to be an obstetrician. Well, they don't really, but they've been excited by their experience of being involved in birth. And I say, well, trust me, if you want to do it, but it's going to be extremely hard for you to be trained. And that really worries me, that sort of discrimination at the most basic level. Obviously, end-of-life care is now my main interest, well, not my main interest, but an equal interest. And that worries me too, because, again, at the Mater Hospital, we're quite clear on where we stand on it, like we are at St Vincent's or anywhere else. But I fear for people who have the same view as I do, who don't work in a Catholic hospital, and I think they will have increasing pressure put on them as well. And institutions that are Catholic hospitals funded by the public purse are going to experience the same thing. So that sort of discrimination and the right to conscientious objection, both personal and institutional, is going to be challenged more and more. Yeah. And it's mainly my concern, and the point of saying what I've said is, I think training people is going to be difficult, because the third parties, the people who identify colleges and governments who pay bills, are going to demand things of trainees that trainees may not want to participate in?
Well, a couple of things, and let me pay respect to the fact that you've given 55 years of your life to medicine. I could never do what you do because I'm no good to anyone at 3 a.m. now.
You only worked 100 hours.
I did the night shifts, but I got home to sleep. I think we've just got to keep pushing back against the hostility with empathy. You know, I think about the situation. We're talking about a doctor's role. You could have two GPs, one who's in suburban North Sydney and one who's way out in the middle of, you know, far western New South Wales, the only doctor in. And they have a conscientious objection to issues around termination, but a 15-year-old girl turns up. How that care is ethically exercised is very different in both situations. And without compassion and empathy in both of those situations, I think we're falling short of our expectations as doctors. I think you're right about public policy, that the envelope continues to get pushed. I said in 2017, that in the context of the end of life debate, that things that are being described as safeguards today will soon be called obstacles and hurdles to good care. And that is coming to pass. How do we push back? Yeah. And to be practical, and I've been involved in politics for decades, you know, the dollars that fund Catholic hospitals they come from the taxpayer, but the taxpayer, many of them are Catholic as well. And not just Catholics share our body of opinion on these things, and there are Catholics who disagree with us too. So there is a heterogeneity. I know for people at the end of life that sometimes going to an institution where they know that there is the philosophy that Catholic institutions would have is a source of comfort to them. Who are we to deny them that? So how we argue that, and I dare say there will be times when we have colleagues who become examples who are sanctioned as a result. We need to support them. Thanks, Xavier.
Thanks so much, Steve. I'm a strong believer in conscientious objection, and I'm also a strong believer in finishing on time, so I'll be brief. I'd just like to thank Steve again for a fantastic lecture, so let's give him a round of applause.